Thank you very much, Professor On, Professor Chang, ladies and gentlemen. It is my great pleasure to participate in this prestigious session as a speaker. This is my disclosure information. Let me start with the history of papillary muscle ventricular arrhythmia. In 2008, Dr. Hui and Neil K. reported the ventricular tachycardia originated from the posterior medial papillary muscle, and they visualized the PAP by LV angiogram at the time. In 2014, Keating and Jiangman reported the papillary muscle VT from anterolateral papillary muscle. Look at the ABL positive QRS waves. In 2010, Crawford, Moradi, and Vaughan first reported right ventricular papillary muscle origin VT, and in this paper, they localized the PAP ventricular RB papillary muscle utilizing the intracardiac echo. In 2015, Santoro and Natali reported 8 cases of RB septal papillary muscle origin VT. Then, what are the ECG characteristics in this group of the patients? We know there are 2 major papillary muscles in LV. Posterior medial papillary muscle is more apically displaced than anterolateral papillary muscle. However, most of papillary muscle had a huge variation or multiple hairs. So QRS morphology of LV posterior medial ventricular arrhythmia is like this. Firstly, the V1 shows the RBBB morphology. Because the posterior medial papillary muscle is more apically displaced, V345 shows negative QRS wave. However, anterolateral papillary muscle shows positive QRS in V345. Also, the posterior medial papillary muscle shows the northeast axis, so ABF negative, lead one positive. In contrast, anterolateral papillary muscle ventricular arrhythmia shows the ABF positive, lead one negative, so southwest axis. Differentiation from the vascular VT is an important issue. Brisano reviewed over 100 cases of PAP ventricular arrhythmia, and PAP ventricular arrhythmia shows the wider QRS width and unusual RBB morphology in V1. In other words, bigger the first R wave than second R wave compared to the vascular VT, and more importantly, small Q waves in V1. Personally, I look for these small Q wave in V1 and the absence of Q wave in ABL. Those favors a PAP ventricular arrhythmia. What about the ECG morphology of RB papillary muscle ventricular arrhythmia? There are 3 papillary muscles in RB: septal, anterior, and posterior papillary muscles, and the moderate band easily connects anterior papillary muscle. In RB origin ventricular arrhythmia, precordial transition changes to later, and QRS becomes wider as ventricular arrhythmia focus locates apical free wall side. Therefore, from septal to anterior papillary muscle and posterior papillary muscle, precordial transition appears to be later comparing to septal to posterior papillary muscle. Look at the precordial, and QRS becomes wider. Also, axis change from south axis to north axis, so you can appreciate precordial negative concordance and wider QRS, and superior axis lead ABF negative in the posterior papillary muscle ventricular arrhythmia, comparing to the RB septal papillary muscle arrhythmia, ABF positive. Now let's move to the mapping and ablation technique of PAP ventricular arrhythmia. ICE visualization became a class 1 indication during the PAP ventricular arrhythmia ablation, and this is my tip to visualize papillary muscle by ICE guiding with stability. If you locate parking the long sheath in the RB, even though the tip of the ICE catheter is inside of a long sheath, you can stably visualize papillary muscle like this. This is UPenn protocol for PAP VT ablation, and they are using Carto sound and ICE guided under ACT over 300. Based on activation and pace map, they apply 30 watt per 90 seconds at the target site with contact force over 5 grams. However, contact force is less than 5 grams. They increase the RF power to 50 watts. If there is a PV suppression or acceleration within 30 seconds of RF delivery, they deliver additional 60 seconds, so over 90 second burn. If arrhythmia could not be eliminated due to catheter stability, UPenn group tried to exchange RF catheter to cryocatheter because cryocatheter stick to the papillary muscle target site during freezing. Because freezer max is too tough, they recommend 6 millimeter tip freezer extra. There were many reports regarding the PAP VT originating from papillary muscle tip or shaft, and that's why ice monitoring is essential during PAP ventricular tachycardia ablation. And in this Lin and Dixit report, over 60% of the successful ablation sites were tip or shaft of the PAP. And you can appreciate the papillary muscle morphology is not that simple in this human heart specimen. If PAP VT originates from papillary muscle tip or shaft, it can exit to multiple basal sites. And in this paper from Yamada group, even though PAP pace map shows a good match, sometimes we cannot eliminate PAP VT because the papillary muscle shaft's complex and special conduction pattern. In this case, both activation map and electron quality was acceptable, but the contact force was too low. In this situation, you need to make a decision to increase RF power to 50 watts or exchange to cryocat. Rivera initially reported the papillary muscle tachycardia ablation during cryocatheter. They reported the sticking of catheter tip to the target site during freezing and 100% of a success rate. Whitaker recently reported the cryocat ablation of RB posterior papillary muscle and moderate band origin ventricular tachycardia. Sometimes QRS morphology changed from posterior septal papillary muscle to anterolateral papillary muscle. Look at the lead ABF. It was initially negative QRS, but during RF burn, it changed to positive wave. It is because papillary muscle, two papillary muscles locate very closely, especially in patients with structurally normal heart. This is the outcome of a 137 papillary muscle ventricular arrhythmia ablation in UPenn group, published by Dixit. In their ablation registry, 6.4% of overall ventricular arrhythmia ablation was PAP ventricular arrhythmia, and 60% of patients with PAP ventricular arrhythmia have associated with structural heart disease, and mean ejection fraction 42%, 71% were PVC, 7% shows a ventricular fibrillation, mostly done by radiofrequency, but the 12% underwent adjunctive cryocat ablation, and the long-term success rate was 82%, and complication rate 3.6%. There were 1 case of aortic dissection, 2 cases of hemopericardium. In this paper, the main contributors to the improved success rate of PAP ventricular arrhythmia are using intracardiac echo and cryocatheter. Okay, then is it safe to burn papillary muscle? Actually, papillary muscle has an endartery supply and risk of rupture or acute mitral regurgitation. There was an old case report for papillary muscle dysfunction after surgical cryoablation. However, in this recent study by Edward and Nguyen, ICE-guided PAP ablation safely protected their papillary muscle dysfunction, but they mentioned that the risk of valve dysfunction could be higher without intracardiac echo monitoring. Finally, I would like to mention the PAP ventricular arrhythmia could be associated with other arrhythmias. In the patient with idiopathic vascular ventricular tachycardia, we previously reported the successful ablation site of this reentrant tachycardia exists around the base of posterior PAP. And Komachu and Nogami systemically proved the vascular VT originated from the papillary muscle. My junior colleague Jason published the accessory papillary muscle or papillary muscle hypertrophy as independently associated with sudden cardiac death of unknown cause. And accessory papillary muscle and papillary muscle hypertrophy have 3.5 times and 5 times higher risk of sudden cardiac death, respectively. This is an autopsy slide kindly provided by Professor Nogami, and this patient underwent successful ablation of ICD storm. However, patient passed away due to pneumonia and underwent autopsy. You can appreciate successful RF lesions at the posterior septum, including the posterior medial papillary muscle. So in conclusion, ladies and gentlemen, PAP ventricular arrhythmia has a non-reentrant mechanism, and 60% of them appears from the tip or shaft of the papillary muscle. ECG is useful for localizing papillary muscle ventricular arrhythmia, and the differential diagnosis from vascular VT is important, and small Q wave and their pathological shaped RBBB and B1 and wider QRS is useful to differentiate. And the RV papillary muscle VT from septal anterior to posterior PAP, those shows the later precordial transition and superior axis. And intracardiac echocardiogram is a class 1 indication to localize PAP ventricular arrhythmia and improve the long-term outcome. And the cryocatheter ablation is effective in eliminating PAP ventricular arrhythmia in case of poor catheter contact. The risk of a post-procedural mitral valve dysfunction is very low on the ICE-guided procedure. Finally, PAP ventricular arrhythmia can be associated with vascular VT, idiopathic VF, or ICD storm. Thank you very much for your attention.